Dear colleagues, as we unfortunately had to cancel this year's World Congress in Montreal, we thought it would be a good idea to at least share some highlights from the virtual Congress that took place in February. Before the video starts, I would like to announce that the 2022 World Congress in Taipei, Taiwan will take place from June 9th to the 12th. I look forward to seeing you there in person, and now please enjoy the video. Oh, and don't forget to subscribe to our YouTube channel below for free so you can watch more videos in the next weeks. Thank you. Thank you, dear colleagues, for attending this symposium. And I will be giving the introductory talk. My name is Pierre Blier, and I'm the president-elect of CINP. So what are the differences with respect to partial or full agonism? So a full agonist is a substance that binds with high affinity to a receptor and lead to full receptor activation. An antagonist, again, has a very high affinity for the receptor, but will just cover it and will not engage any physiological function. And a partial agonist binds again with high affinity, as I've shown you, and will produce a partial activation. So if we try to illustrate that in a more quantitative manner, you would have here an in vitro system where you have expression of a dopamine receptor and you're measuring a dopamine response. So as we increase the concentration of a full agonist like dopamine, then we engage the receptor with full activity. There's no dopamine in this system at baseline, so an antagonist will not do anything to the receptor activity, and a partial agonist will actually produce some physiological response, but at one point becomes really concentration independent. But that may not mimic the concentrations of dopamine that we have in the normal brain or in the brain with somebody with schizophrenia or mania. So if we start by activating the receptor by putting in dopamine and then introduce an antagonist, then the response will be diminished as the antagonist will displace the full agonist. And actually a partial agonist will do the same thing, will turn the dopamine dial down just as the antagonist, because it will compete and displace the full agonist. So if we shift more to clinical issues, when considering selecting a medication, whether it's for mood disorders or for psychotic disorder, there are different receptor properties that are important to take into consideration. So the newer agents like olanzapine and risperidone have a higher 5-HT2A than D2 affinity, and therefore they lead because of this property to less extrapyramidal symptoms, but other properties may contribute, like activation of 5-HT1A receptors, blockade of alpha-2 adrenergic receptors as well, and I'll show you how this is relevant. So we go back to our table here of affinities for the three partial agonists, and you can see that they all have a fairly high affinity for 5-HT1A receptors. They are agonists at these receptors, but also 5-HT2A antagonist activity is present. But here with cariprazine, I put a question mark because it's quite different from the other two compounds. So we have to wonder, is this a significant affinity in vivo? Well, again, so these drugs, especially aripiprazole in schizophrenia, the mean effective dose for psychosis is about 25. For adjunctive treatment in MDD, it's about 10. For schizophrenia, brexpiprazole, it's about 3.5 milligrams per day. And for MDD, it's about 2 milligrams per day. So you see there's basically almost no overlap between what's used in psychotic symptoms and in depression. But our clinical experience in MDD has shown us that aripiprazole should really be on the very low side, and as well for brexpiprazole, so as to not decrease dopaminergic transmission. So the transition dose between partial agonism to enhance dopamine transmission or to decrease it is about this dose level. So in summary, dopamine partial agonists can decrease dopaminergic transmission when there's an excess of dopamine, and in contrast, They may enhance dopamine transmission if dopamine is normal or if it's too low. And these three medications, very importantly, have distinct pharmacological properties at monoamine receptors. And then finally, our controlled studies and clinical experience have taught us that the dose range to be used in depression should be lower in their effective regimens in mania and psychosis. So low doses for depressive episodes, higher doses for mania and psychosis. And thank you for your attention.
My name is Stephen Potkin, Professor of Psychiatry, and I'm happy to be part of this session and welcome to it. I'll be talking about the clinical effects of long-acting injectable Aripiprazole in schizophrenia. I'm looking forward to your questions about this presentation later. I will be discussing a study. And one of the things we should keep in mind that non-adherence of antipsychotic medication is frequent and associated with poor outcome. Adherence is primarily solved by using depot injections of antipsychotics. A question that comes up, are there differences in efficacy or side effects among the available depot antipsychotic drugs? In this tile, we'll be able to compare a D2 receptor antagonist, Invega or paliperidone, a depot that's given once a month, with a partial agonist, Abilify Aripiprazole, which is a depot given once monthly. Both of these drugs are used widely, and both are well-documented effects. They interact with receptors similarly, and they have similar kinetics and have simpler glycoprotein effects. D2 receptor antagonists, 5-HT2A antagonists, and 5-HT1A antagonists. This study contradicts two antipsychotics that have different, very different mechanisms of action. D2 antagonists versus partial agonists in schizophrenia. What we should keep in mind as we start this study is, what do we expect from both drugs? Do they decrease psychosis, improve negative symptoms? Is there a difference in motor side effects? Better alertness, less sedation, improved cognition, normal motor gait, less weight, better lipids. Okay. In this study, one of the things we predefined that we would invest the age of patients on outcome. So we tried to accumulate patients that were less than 35 years and those who were greater than 35 years of age. And we'll discuss the results. Now, we had some other scales, and we'll talk about as we go through this, that were measured as well. And what's interesting that some of these scales were a blinded rater. He had no idea, or she, what treatment they were getting, aripiprazole or paliperidone. Also, there were patients themselves that rated themselves, and there were various scales they took that measured everything from their how they were doing and what symptoms they were having trouble with. Okay. Now, we also measured their well-doing, how they felt under neuroleptic drugs, and their quality of life, their sexual experience, and their ability to work. And this shows essentially the improvement of Abilify over paliperidone. Now, what we can see here, there's 28 days, and you can see in the gray, we showed that patients improved with paliperidone. which is what we expected and good. But now when we look at Abilify, patients improve, but they improve throughout the treatment. And they differ from the patients on paliperidone as early as the second and continued improvement throughout the thing. Now, you may not be familiar with the scale, the QLS scale. So what does the difference mean? We see essentially the paliperidone, they showed an improvement about 1 point. What does that mean? So we have something which is called the minimal clinical identify difference. So in a different scale, they established something that you could notice and would make a difference and people would want to get is 5 points. And what we see in patients on Abilify got more than the amount, the 5.3 points. So this is not only is a statistical difference, but meaningful, which is important. Now, this now looks at the different domains of the QLS, and you can see every one of the domains we see: interpersonal, instrumental, common symptoms. All cases we know that aripiprazole beat paliperidone in this regards. Okay, difference important. So let me now take a moment to summarize what we talked about. In treating patients, we do see adverse events, and most of the reasons for discontinuation, and that was much greater in paliperidone than it was in Abilify. Now we talk about the dosing was for Abilify 387 and 171 for paliperidone, and these are what you would expect in treatments, is about what you'd expect there. The primary outcomes showed improvements on the quality of life scale from base and week 28 for both the Abilify and also for the paliperidone. However, the Abilify, much greater improvement than paliperidone, much more. And that the difference between the treatments was just about the MCI, a meaningful, identifiable difference. Okay, and we see this on all the measures as well. And the change from baseline to week 28 showed greater improvement on the Abilify 400 mg to the paliperidone. Okay, so this is the statistical difference, and I think meaningful. The idea that people have a better chance to be able to get a job and return into life makes a meaningful difference for patients, and I think is an important availability for patients with schizophrenia as they try to re-guide their life after they become ill with schizophrenia. So I now look forward to your questions about the scale. Thank you for your attention.